Well, it is fun to share the stage with Stephen. You got to hear a little bit about Steve Muthing's family. I have 4 children and 9 grandchildren, and both my daughters, one's a physician, one's a nurse practitioner, both work in safety net clinics. And my son, Stephen, speaks all over the world on healthcare innovation. And the women in the family say, what the devil does he know about healthcare? He's never taken a science course in his life, but he's figured out that it's the different voices that we all bring to the table that has driven a lot of his work. I have to share with you that I'd rather be sitting in your chairs than up here this afternoon. I've given after lunch talks a lot of times, and I know you all want to take a nap. But it is totally unfair to follow Derek, Steve, and then Shakespeare. I mean, really, that is just more than any human being should have to be able to endure. So I'm grateful you're here. I hope we can have some fun together and look at healthcare from yet another different perspective. The Institute for Patient and Family-Centered Care is a nonprofit organization. We're based in Bethesda, Maryland, but we work all across North America and around the world. Our sole mission is to advance the understanding and practice of patient and family-centered care. So I hope we'll be a resource to you. Our website is there. I enjoyed having lunch with some people who work with the Medicaid agency. We have a brand new section on our website where we talked with clients of Medicaid and Medicaid directors and staff who work in those programs to really think about how do you integrate the concepts of patient and family-centered care in a Medicaid agency. So just one example of some of the things that we're working on today. But what I was asked to talk about today was really about these partnerships for quality and safety. And I think you'll see themes from Derek starting the day, weaving it through, and then those just inspiring awards recognizing great leaders in South Carolina. I'll spend a little bit of time really just helping we make sure we understand and have a shared understanding of what patient and family-centered care means. I'm going to talk a little bit about how you reliably integrate these concepts across the continuum of care, and talk a little bit about the benefits and the role of leaders. So what is patient and family-centered care? It's an approach to the planning, implementation, and evaluation of healthcare that's grounded in mutually beneficial partnerships. Those 3 words are really important: mutually beneficial and partnerships. And it's got to work for patients and families, but the system of care has got to work for people who work in it as well. And we start off with the first core concept of patient and family-centered care is respect and dignity. And you certainly heard that from the beginning of, with the Cleveland Clinic video around empathy to Derek's and Steve's presentations. And we talk about it as everyone needs to be treated with respect and dignity. Every patient, every family, and all the people that work in the system, whether they're in the hospital, the clinic, the community, all of the relationships are grounded on respect. If we want a high quality, highly reliable, safe, cost-efficient, patient and family-centered system of care. The second core concept is that we share information in ways that are useful and affirming. And that's a teachable skill that all of us can learn, and I think we need to look at our hospitals, our clinics, our agencies, and look and see if we are in fact sharing information in ways that are useful and affirming. And you can't figure that out unless you talk with patients and families who you serve. The third is, and we know we get the best clinical outcomes when we encourage and support the active involvement of patients and families in care, care planning, and decision making. There's been lots of talk today about empowerment. And I have a funny thought process related to empowerment. I don't think through healthcare that we give power to families. We have to not take it away. And so many of our policies and practices and communication styles, we fail to help patients see the power they have within themselves. So I think we have to look at how we train people, how we teach those communication skills to really encourage and support patients in participating in their own healthcare. And lastly, it's collaboration. And while it's collaboration in the clinical encounter, it's so much more. It is those partnerships in improving care, improving the experience of care, improving quality, safety, in teaching the next generation of healthcare professionals across disciplines. It's in research. And we'll talk a lot about what those partnerships look like. A simple definition of patient and family-centered care is working with patients and families instead of just doing to and for them. And one of the things that I love to do best when we work on site is look at an organization's key documents and look at, where do we spend a lot of our money in healthcare? It's on people, on personnel. So you want to make sure you're integrating these concepts in your human resources system. So what's the behavioral expectation for how you work with patients and families? It's that little word with should be built into the position descriptions for a hospitalist, for a physical therapist, for a nurse, for everyone who works in healthcare. And now, a lot of the literature talks about patient-centered care, but I think it's really important that we not leave out that word family. There's lots of data that talks about social isolation is a risk factor, and I'm excited about the efforts in South Carolina about population health, because I think lots of people, even in our crowded urban communities, are living in social isolation. So we don't want in healthcare to impose social isolation on the people that we care for, that we separate them from the people they know best by our policies and our practices. And if you look at it, hospitals and clinics, the people that are most dependent on your care are the very young, the very old, and those with chronic conditions. And they're the very people that need extra folks to help them in managing their health care. But I think you can, and I love the title of this symposium, that we're talking about transformational changes. Those not just ors, but ands that we've got to embrace to really bring about profound change. And I think we can't do it as insiders in healthcare. We need patients and families, and I use that term patients very broadly, and that's people and families and communities working in partnership with us. I hope you'll go away, and I've put a lot of references and resources at the end of these slides that I understand will be available on the website. But here's an article that was written about 5 years ago. But all the key leaders, and certainly Lucian Leap and Don Berwick and Carolyn Clancy, Jim Conway and others, it's a very short 4-page article in the BMJ. And the part around really partnering with patients and families is 4 paragraphs. And I hope you will take it back and have leadership discussion about what does this mean to our organization. But one of the things they say in this is that organizations publicly commit to patient and family-centered care. That means that everyone who works in that organization and all the community, the public you serve, understand this is our approach to care. And those core concepts, respect and dignity, information sharing, participation, and collaboration, really guide the practice and the experience. They also say that family is respected in every part of the healthcare organization. They're not labeled as visitors. Please remember that, and I'll come back to it in a moment, that families are respected as part of the care team, not labeled as visitors. And in ambulatory care, that the model of care needs to be collaborative self-management support, where we're really supporting individuals in managing their health care. I'm a fairly new type 1 diabetic. You're going to get to know a lot about me and my family, and you need to know that Stephen never wears the same color socks on both feet. I don't know whether that's innovation or just we didn't teach him very well. But I have to manage my diabetes when I'm on the road. My healthcare team is not here. I just checked my blood sugar before I got up here. I'm feeling pretty good because if I get in trouble, you all are going to help me, right? And those wonderful residents that you were honoring earlier, I figured they know about high blood sugar and low blood sugar, and I'm in good hands. But normally, we've got to help people manage their health out in the community. Don Berwick spoke at our international conference a couple of years ago, and he talked about the triple aim and that the concepts and strategies of patient and family-centered care can really help you. It will be the most direct route to achieve all three of those goals of the triple aim. Another great reference for you is the Institute of Medicine's book, Best Care at Lower Cost, The Path to Continuously Learning. You all are so impressive about what you've done over the last decade or so. It's really been wonderful to watch from afar, the incredible progress you've made. But what the IOM report here is saying is you've got to have patients and families as part of the learning team in your organization. And that just doesn't mean having a counselor who's stuck over there, but having them side by side working with you on quality and safety teams, where they're selected and prepared and supported to be active, meaningful participants with you. I've served for a long time and have learned so much from the wonderful group that works with the American Hospital Association's McKesser Quest for Quality. This is an award, and one South Carolina hospital has been a winner, at least I know of one, which is very exciting. This is a $75,000 award for really the leadership of a hospital that aligns those agendas of safety, quality, and patient and family-centered care. Originally, the award was a safety award, but the context is really important. You can't do safety and isolation. We've got to link these together. So if you haven't seen the criteria for this award, again, I would take that back and really look at what it's talking about. It also, in recent years, has placed a greater emphasis on equity and access, and to make sure that our healthcare organizations reflect the diversity of our communities. A first step, I think, in building really meaningful partnerships with communities. Another partner we've had is the ashram in terms of risk management. I'm married to a lawyer, but I don't want a single bit of our healthcare dollar going to lawyers. And so they devoted an entire issue a few years ago to looking at what's the intersection between practice of patient and family-centered care and reducing risks. And again, I'll refer more to that, but I think really partnerships with patients and families is a proactive risk management strategy. 9 months ago, I guess, we launched an international campaign really out of many decades of frustration that hospitals across North America and even beyond still label families as visitors, still have limited visiting hours. Every time I say the word visit, visitation, visiting, I'm putting quotes around it because I want you to go away thinking of families, however they're defined by the patient, as allies for quality and safety according to the patient's preference. So finding out who their family is and supporting them in the ways the patient wants you to support them in their health care. So we have on our website a whole set of free materials to help you change the culture of your organization. But we're not going to make progress in so many of the important things of reducing harm and improving the transitions of care if we continue to label families as visitors and use those words of, oh, we have open visitation. It's like nails on a blackboard, and that we allow families to be together. What degree do we have that enables us to keep patients away from their loved ones? And I hope South Carolina will think about what they do with this. New York has done a study to look at where their hospitals are across the state. And last night, I was told that you all had decided that you all have already done this. You're ahead of the nation. The data is 80% of ICUs still have some limitations on families being present. And it's not the patient's preference, it's the hospital policy. So I came back, I was late, I'd traveled, flown in, and I looked at a zillion hospital websites for South Carolina. It's not a scientific study, and I guess if this is on camera, you'll be glad I'm running to the airport after my talk. But I didn't see a single example that truly proactively welcomed families. I saw the label on the website that said patients and visitors, and there wasn't then you're part of the team according to your loved one's preferences. We want to work with you. You'll be part of the transition. So I think you still have a little work to do. This is Contra Costa Regional Medical Center in Northern California, and they went from a visitor control policy to we welcome families. And this hospital not only is caring for the people in the community, they also are, the CEO is in charge of prison health. So it gives you a sense of the diversity of the community, of all different kinds of people getting care here. And they have partnered with their security department, with their frontline nurses, and truly it is a sense of welcome. Ashram says, welcoming families, supporting their involvement is proactive risk management. Now, I want to share with you a story. I think if we're going to really transform our healthcare organization, storytelling is a skill set that we need to have with all leaders in healthcare. I'm sure you know the wonderful physician Rachel Raymond, who wrote Kitchen Table Wisdom among many other books. Facts bring us to knowledge, stories bring us to wisdom. So I'm going to share a little story, and it was interesting to me, and there's maybe some connection. And when I learned Helen Haskell's organization, Mothers Against Medical Error, is the same initials for MAME as MAME's story today. So there may be some connection there. MAME's story is a story about my mom. And you can see she's pretty with it. And this is a picture I took this summer with her youngest great-grandchild. I don't know who's more engaged in the book. This summer, I left a message on her phone. She lives in Florida. I live basically in Washington, D.C. And I asked, you're not home. You must be out. And her social schedule is busier than mine. And turns out that she was in the emergency room. And I then get a call saying they're suspecting that she has a blocked intestine. And the ER physician is saying, I've called a surgeon in, but they're really, if we don't operate, your mom will not live, and surgery for a 101-year-old. Well, the surgeon comes in, gets on the phone. In the meantime, I have my daughter on the other telephone. So this is shared decision-making. My mom was not in the room at that point, but as the surgeon moved with his cell phone, I could hear my mom's voice in the background. And he explained the situation, said, I think she can survive 45 minutes of surgery. Before I even got in the room, they told me about your mom and how mentally alert she is. But this is a choice that you all must make. And clearly my mom was the decision maker, and I could hear through the phone, go for it. So that's what shared decision making looks like. Do you get that? And I want to tell you that I think she's alive today, one, because there was really good skill in that care. Two, the nurses and the physicians were incredibly caring and compassionate. Really made a connection with my mom, and she is a people person, and I think that gave her will to live. It's not just family, but that made a difference in her care. But what really breaks my heart, and I think has huge implications for safety, quality, the transitions to home and community care, not a single person in that ICU knew how to collaborate. So let me give you just a couple of examples. I am there as my mom's daughter, not as a healthcare professional working to bring about change. So I go in and I see, we are very proud, we have open, did I just do that? There. We have open visitations, and you are allowed to be here all the time except for 6:30 to 7:30 and 6:30 to 7:30 morning and night. You all know what that means, that shift change. So I very quietly went out of the room and talked to the nurse in charge and said, I would like to be there when you do change a shift report, because I help my mom coordinate her care. And while she's mentally very alert, she's on pain medication, has just had general surgery, and she doesn't track so well. So she needs me to help her through the transitions. They said, no, we couldn't possibly do it in this single room ICU. And I said, oh, please, I think I can help you, and I promise I won't take more time. It said it would be a HIPAA violation. I said, it's a single room. And my mother is saying, please let me be there. Finally, she said, I can tell you're not going away, basically. And she said, if you stay in the room, we're going to shut the blinds on the doors and the windows so no one sees you. Can you imagine what I felt like? Talk about respect and dignity. So I think we're okay. I helped my mom figure out the do not resuscitate order. She wasn't going to check all those things, but we needed to figure it out. And we signed it. The nurses watched it and then said, we're going out in the hall now to do change of shift report. I said, oh, no, my mother would like me to stay and you do it with us together. Oh, no, we couldn't because it's a HIPAA violation. And then I said, but we're in a single room and my mom wants it. And the next piece was, we're going to talk about her systems. And my first reaction was, terrific. I'm going to learn because I'm going to be the one in the community. You've got this wonderful chance to teach my mom and to teach me. And by 2 or 3 days from now, my mom can really be learning, but we can then have conversations to help keep her healthy. Absolutely no. And out into the hallway, they did change a shift report. So I'm at the point, folks, when we make HIPAA violations and misinterpret HIPAA, that ought to be cause for correction and not so much, oh, we shared information too broadly. We have misinterpreted HIPAA. So I wish I had more time to tell you the other aspects. I'll just share a couple of other things that they were not able at the front lines to provide me with copies of her med list, copies of the DNR order that we signed, and the limitations on it, and I clearly asked, my brother lives here, and I'd like him to understand what her preferences are, so if he's supporting her when I'm out of town, he could do it. And they could never, frontline people could not hand me that piece of paper. No physician was able to come into the room and summarize the care that had happened with us over the last 24 hours and what was the plan for the next. That's, again, collaboration, and we need that, and it's a teachable skill. And I hope that story, there were so many good parts of it, but there was a lot to learn in that experience. And you have to know that she picked out her basketball teams for the basketball brackets, so she's doing okay. So we are grateful. I think of this book, Privileged Presence, is really Liz Crocker's book from Canada. There are about 60, 65 stories. You can use it in sharing stories and interpreting these stories. They're told from the perspective of patients and families, nurses and physicians, leaders and others. And so they've been used in various health systems to help get a spirit of storytelling so we can learn from it. We don't profit at all from that book. I want to share with you a health system's commitment, what it could look like across a health system. Vidant Health in North Carolina, so not too far from here, at the board level, they're committed to patient and family-centered care. One of the key things they have done is to make in the quality strategy that they will partner with patients and families. So that when they created 6 or 7 years ago their 5-year quality and safety plan, they very clearly said quality and safety work is patient and family centered. So how can we build those partnerships at all levels of the organization? They had for years very restricted visiting hours. And it was finally one of their staff who shared their story. And you can go on our website or their website and see the power of the story that finally changed. And at the board level, at senior executive level, this is a leadership issue to change the concept of families as visitors. So that cardiac clinic with all those restricted visiting hours, I finally said to them, I'm not coming back until you fix this. You just can't have this kind of a model of care. And they changed it to welcome to North. That's all those signs came down, and that's what it said. Think what that does to family shoulders, how they can relax, and then they don't have to fight the system to be part of the system. And then if you're a cardiac patient, we're in this together. We want to, we want families and patients to be part of the care team. So they're educating the public. We have conditioned the public to be passive recipients of care. So they've got messages on their website on your role as a family member, your role as a patient, and what to expect, and putting them on the quality and safety teams as patients receiving care. They also have a, I know you all have some small critical access hospitals here. They have a 6-bed critical access hospital on the coast near the beach. And when I asked about it, they said they have a 12-person mighty patient and family advisory council. And what I love is the CEO and the chief nurse attend meetings on a monthly basis regularly, and they tour the hospital. Well, if you have a 6-bed hospital, it doesn't take you too long. But they have a very robust emergency room. So they're modeling partnership out there together. And what I hope, and Rick, with your new responsibilities, they view their advisors as the link to the community. They know more about community health and community resources and community issues. So that is the way they're beginning to think about population health in their little tiny hospital. They also, in their rounding, many of the leaders round with the patient and family advisors. These are people that have been selected, supported, trained to be able to do this and to bring their vital perspective. And some of them even have the skill set now that they round on their own. And they come back and share what they have learned with clinical leaders. So each of your hospitals could have patient and families like this. When Caroline received that wonderful award this afternoon, and so generously said, you can have people like me in your hospital. I hope that you really heard that, and that you too will be partnering with them. One of the things when the patient and family advisors round on their own, they ask this simple question: is there anything that makes you feel unsafe or uncomfortable? A great question to ask. And they feel safe in sharing it because it's someone like them. And so you get these honest discussions. One of the CEOs of one of their hospitals, when he is hiring a new physician, he asks them 2 questions at the beginning of the interview about whether they embrace patient and family-centered care and whether they embrace just culture. And if he doesn't like the answers of those 2 things, it is a really quick interview. And that person is probably not going to be part of the team. So you want to be hiring the right people with the right attitudes. You can build on skills. They now are beginning the process of involving patient and family advisors and training them to be part of a root cause analysis. It's not the place you start. You build trust with your advisors and then invite them to be more broadly involved. They're very involved in the work around improving transitions of care and reducing unnecessary readmissions. One of the things that I was so excited about the work across the nation about trying to improve transitions of care, what was sad to me is so many of the hospitals and health systems tried to reduce unnecessary readmissions by having staff do all the figuring out what's wrong with the system. Who knows best about those people? I bet none of them know that every hospitalization my mom has had in the last 18 months, there has been a lag time of 24 hours for her to start her drugs. And she ended up with RSV, which I thought only premature babies got. But the system breaks down, and I saw it from our side. And I could have brought something to help them improve the system of care. Here's some of the improvement in Vidant. It's around the patient experience, it's around safety, around quality. You know, they are not pretending that advisors have made all the difference. They're doing a whole lot of things. But I think that to go from 20 advisors in pediatrics to 112 that are serving on the IT implementation team and teaching clinicians and on quality teams and rounding, I think that you have to say they're a part of this improvement. So what's it look like a little more specifically in lots of little examples? You know, as Lucian Leap has said so many times, you know, if health or healthcare is on the table, then patients and families, I don't love the word consumer, so I choose to use the word patients and families and communities, should be at the table. And you heard from Steve Muethling this morning, the former CEO of Cincinnati Children's, said, you may not know how to partner with patients and families. Get started before you're ready. And the good part is, you can be transparent and say, we're learning how to do this, and we're going to do it in a way that we all learn together, and we're going to be transparent in that learning. The Children's Mercy in Kansas City, their leaders created a policy and a video that said we are going to partner with patients and families in all of our key working committees that are relevant to patients and families. And they appointed 3 moms whose children get care there to lead the Department for Patient and Family-Centered Care. And you can see with this chart the growth of the number of advisors once they appointed these moms as staff leaders to encourage this work. And just, they got stuck in the nephrology clinic. Families kept saying, we don't have the kind of information we need to care for our children with chronic kidney disease. And so they put patients and families on the QI team. And they helped redesign the information materials together. Patients and families didn't have all the answers, but they had some of the answers, and so did the clinicians and staff. And so working together, you can see the beginning of improvement. Some of you have a lot of new ambulatory clinics and maybe working on the patient-centered medical home. And I know you can't read the detail in the charts, but I wanted you to see a multidisciplinary physician practice that to the left high box is the executive committee, and on the right side, reporting directly to the leadership of the group practice, is there are 3 committees: quality, finance, and the Patient and Family Advisory Council. That's where you visibly make it apparent in your organization and you support them. These 2 women are among their advisors. They call themselves the DVD Divas. And the medical group sent them to a statewide safety meeting. Maybe they came to South Carolina from Oregon. I kind of doubt it. I bet they stayed on the West Coast. But they learned so much. And the group practice gave them $5,000, which they leveraged in the community to produce a video that you can go to their website. And it is about safety. It's about how to get the most out of your short visit and how to manage your medications, all driven by patients and families, so it's meaningful to them. At Harvard, some of their very smart physicians came up with an idea that cancer patients would learn about safety and they would stay an hour after their chemotherapy to take a class. How many patients do you think stayed an extra hour after receiving chemotherapy to go to class? 0. And what was great about these folks and being transparent and learning was they realized they should have asked patients and families to help them figure out how to do it. That was not the right way. So together they created a campaign, they published work on this, and it was how, through a campaign and posters and short messages, to how to teach patients to be on their own safety team and support them in that learning in a way that worked for them. This is another critical care access hospital that has a partnership council, has patients sitting on the quality and safety committee. I'm going to show more data about the incredible work that they're doing. But they look at the growth in terms of HCAHPS scores. They have only had this commitment to patient and family-centered care since 2009. And they've educated every single employee, and they're now in the process of re-educating all of their employees. And they can look at, this has become their business model. Anne Arundel Medical Center is a large community hospital, and I think the implications for you all in terms of their leaders pick a goal. Their executive team picks 1 or 2 goals for patient and family-centered care every single year. And they are started off as a really good hospital, but they're even better today because of what they started in 2009. And all of those, everything from even reassigning hospitalists geographically, they worked on with patients and families. And you see pineapples all over their hospital. And you don't grow pineapples in Annapolis, Maryland, but it is the symbol of welcome. And they transformed how families felt and how secure patients now feel that their loved ones can be with them 24/7 according to the patient's preference. And there, again, if you look at the data, they're always in either the first or the second in satisfaction for the state of Maryland. They're recognized as one of the best places to have elective surgery in the country by Consumer Reports. Emory Healthcare, they partnered with patients to teach nurses how to do change of shift report at the bedside with the patient and family, part of the process. It's not enough just to get the geography right, it's how you communicate. And again, they have terrific data. You can do the same. I think a real lever for change in the culture of organizations is the rounding process. And this one, I'll go back and just a quick, the intern is sitting down at eye level with the patient, and they are working collaboratively as a team. The faculty member is helping that intern learn the language of partnership. They did a study and looking at nurses say, this is a better way to practice. I was interested to hear about the work around team-based care and in one of the awards around communication. And the IOM did a great, published a great book, I think 2012. And they talked about team-based care, but they were humble enough to say and write an article in JAMA that, oh my goodness, we forgot that patients and families are part of the team. And I love this quote, in high-functioning healthcare teams, patients are members of the team, not simply objects of the team's attention. So you get the sense of partnership on a team. Beth Israel went and partnered with their patients. They thought around discharge planning, they thought all they needed to learn was we got to fix our materials we hand out. Well, that was 5 years ago, and the richness of this partnership of improving transitions of care. This is a kooky slide. I can't seem to get that little disappearing circle out of it. But basically together they designed a teaching tool and a tool that would go on the refrigerator so that it was meaningful for patients and families. Let's see if we can get... Open Notes is another way to build partnership with patients and families, and we've talked a little bit about leadership rounding. At Dartmouth, they have patients and families working in the simulation center, designing some of the curriculum around safety. They have them serving on the Sentinel events review committees, And they have them teaching new residents and all new nurses and nurse interns, all being taught by what I call patient and family faculty. So I want to just, as I wrap up, cover two areas, the role of leaderships, and link this to high reliability. Leaders have to make an explicit commitment to partnerships. And they should say, if we're starting a new clinic, a new program, a new policy, we're not going to do this work without patients and families part of the process. They need at every step of the way, and they should have measurement as part of this work to make sure that it's making a difference. You don't want to do this just to check it off and say, you know, we've got our token couple of patients and families. But if it's not making a difference, I would suggest going back and looking again at the process. It's really key to appoint someone who is going to be the staff liaison to work with and ensure that they're prepared and can be meaningfully involved with your patient and family advisors. So that staff liaison position is critically important. It is also important that the board of directors, I'm going to be in Maine in about 2 weeks, and they're bringing together all of their boards from their entire Maine health system to really learn in depth about patient and family-centered care. And what's the role of the board and senior executives, and what does it look like at front staff levels. And certainly it should be built into the strategic plan, in your annual operating plans, so you can track and measure it. And I hope that as you work on operating plans and strategic plans, that patients and families are partners with you in developing those. So leaders have to convey that the experience of care matters. It is important, and it's important to quality and safety and to achieving the triple aim. You want to make sure that you build it into your human resource system, so I hope you'll go back and review your position descriptions and your performance evaluation and how you're hiring and supporting staff. And how does this connect with high reliability? Well, I'm not friends with the authors, as Steve seemed to be, but I've observed, and the part of my job I love the best is working on site with hospitals. And when you take what I've seen in their organizations, it's not just doing the work, completing the tasks. It's a sensitivity to operations, which to me means how you do it. So it's not just getting in the room and doing nurse change or shift, it's that you do it in a way that respects the patient and family as an integral member of the care team. And that you keenly observe this and you build the capacity within your organization. The preoccupation with failure. I think we need to think about care interactions that don't reflect respect and dignity, that don't share useful information. That is a failure, and we need to address it and make sure that the care interactions 24/7 for all patients is reflective of patient and family-centered concepts. That we really look for an in-depth understanding of why that happened, and we look to patients and families to help us understand the causes behind near misses or serious events. And that you really believe in the capacity and see the strengths in all people, that's patients, families, and staff, and your organization. And that you really, the expertise is across the board. It's the people we serve, it's our communities, but it's those who work at all levels within the organization. So leaders are key. Thank you for having a chance to share a little bit of this with you, and I look forward to spending some time with some of you later this afternoon. Thank you.